My name is Susie Finnerty. I'm here clearly to support House Bill H5619. The evidence is pretty outstanding, and I'm not going to repeat that. So why I'm here, I am the co-president of the Doulas of Rhode Island. We are a professional organization for doulas in our state, and we are the largest network of doulas in Rhode Island. We have 53 members that provide a wide array of services to families during the whole perinatal period. So that would be pregnancy, during the birth, if the pregnancy ends in a birth, and the postpartum. And many people in and outside the organization worked collaboratively on this bill in order to create something that created more accessibility, not just to doula care for families, but also to doulas, which Isabel really articulately explained why it can be a struggle to maintain a doula career in this state and in general. I wanted to address the issue of reimbursement because we have, as an organization, been approached about various models of providing doula services on an unpaid basis. We've been approached about establishing volunteer doula programs. We've been approached about training medical students to provide these services. And these models are not sustainable because the work is incredibly taxing. The lifestyle being 24 hours on call. I don't know of people in our state that are doing this unpaid successfully at all. And in fact, even so the doula profession in general in the United States has a 4-year burnout rate, which I just passed. And I've been doing this for 5 years, and I can completely understand why doulas quit doing this after 4 years. We are underpaid. We can hardly pay for childcare. We can hardly pay our bills. We are witnessing things that are deeply troubling to the families that we're working with and to ourselves and our peers. So I would say that we are here to collab in just a collaborative spirit with anybody who is willing to push this thing through in a sustainable way. We understand that anytime there's money involved, that things need to proceed cautiously. And I hope that you've heard today about the potential cost-saving effects if this were to go through, savings on preterm birth, savings on cesarean sections. But I will say that if this doesn't pass with a good reimbursement rate for doulas, that we are not going to see those outcomes. I also wanted to just briefly mention that we are part of a class of paraprofessionals, and integrating paraprofessionals into healthcare is something that has been successfully done in other portions of healthcare. I think we are oftentimes compared to midwives, which I think it can cause confusion, especially when talking about reimbursement rates. So I worked, when I lived in Oregon, I worked at a mental health clinic, and we were the only private-owned mental health clinic at that time that took Medicaid reimbursement, and this is relevant, I promise. I was around when the professional called a skills trainer was implemented into care and was paid on an hourly basis. This is a person who is not a medical provider but would work in the home of children to address practical needs that would create better outcomes for their mental health. There was great data to suggest it. The state pushed it through, it was implemented, and it worked really well. So just if this all seems overwhelming because the word doula is typically very foreign to people, just know that there are people here in this room that want to collaborate, that want to shine light on the ways that this actually does exist in our healthcare system, and it works quite well. And then one last thing, and then I'll be done. But I am really humbled at all the words that were said about doula care by the medical providers. A lot of times we feel very unseen in the labor and delivery space. And I want to talk about what we see at home, because if you give birth vaginally, you are discharged within 48 hours. Discharge is at 11 a.m. and you got to go home. And the standard of care is that people are not being seen again for 6 weeks. Sometimes this is when we are called for the first time. Not all doulas attend the birth. Sometimes we are called when people are at home and they haven't slept. They are crying. They don't have family support. Breastfeeding is not going well. There are a million reasons why people might call us. But we fill in a major gap, and I have been, just in the last year, in several positions where I have been sitting in somebody's home and had to tell them, like, this isn't normal. Like, we are calling your care provider right now while we're sitting here. And people think that you're just supposed to be miserable in the postpartum, and people get sick that way because they don't know that they need care. And we are not medical providers. Our craft is very important to us, but when you are there in somebody's house and you have this established relationship with somebody, we are able to point people in the right direction in a timely fashion so that they can get the medical care that they need. They can get the resources that they need. We can find them a therapist that takes their insurance. Medicaid pays $1,000 a day for the day hospital, which is where people can receive care for pretty severe postpartum and sometimes pregnant-related mood disorders or different crises. And I know of many times where somebody went uncared for a very long time, and it turned into a huge crisis for them. Anytime we are filling in these gaps for people, there will be cost saving, but it needs to be done in a way that is equitable to the professionals providing those services. That's all I got.